Thanks for coming here. Today, today we have a very esteemed speaker, Dr. Bivek Gupta. Those who don't know him, let me tell you that he is the alumni of the Institute. It is MD from whatever department means. Then he came to us, spent with us 3 years as a resident before he moved to USA. Now he is working as an associate professor in Neuro Clinic, USA. And he is doing exemplary work, especially on cerebral MR. And he is going to take us through a very complex topic, that is the emerging clinical applications. And Dr. Vivek is faculty at in the hospital, and he has over 80 publications in the peer-reviewed journals, and he has several chapters in book. And for last 3 years, he's working in this cerebral MR. He's going to take us through a very complex thing like what is the role of cerebral MR in refractory epilepsy, stroke mimics, demyelinating diseases, and of course the brain tumors, where I think from morphologic imaging, the things have moved on towards the molecular-based imaging. So the real role of cerebral in this area, I think, is going to speak and cover in this topic. Over to Dr. Bivek.
Thank you, everybody, for joining. And good. Thank you, everybody, for joining. And my special thanks to Dr. Gaikwad. Dr. Gaikwad is like a guide for me, guide and mentor. He was my faculty when I joined as a senior resident. And if he had something that I didn't understand and my colleagues didn't understand, he was a first to go person. And so I have a lot of fond memories of Dr. Gaikwad and other colleagues. And going back to my days in late 90s, we were doing some phenomenal work. I mean, this institution does absolutely phenomenal work, and everybody who is associated with this should be very proud. There is no institution like this in the entire world. I think what we learn here is unparalleled, and you cannot, the depth and the breadth of understanding and the hands-on experience is unparalleled. So I'm so grateful that I was able to train here, and I'm so grateful that I was able to come back here and talk to you, share my experience. So what we're going to do today is, and then speaking of 7 Tesla, if I were to ask of you, if you were given a microscope that you could put anywhere in the brain, what could you not do? You could detect every disease, you could understand everything. But unfortunately, that's not possible. We can't put a microscope in a live brain. So what can we do? So we can apply some techniques like CAT scan, like MRI, and try to understand it better. So what we have learned, especially with the MRI, that we can actually go a pretty long distance in understanding the brain when it comes to MRI, because we have several ways of imaging it. We can use T1-weighted imaging, T2, all sorts of contrast, all sorts of sequences. We can modify the sequences, get better. We can go to higher and higher resolution. But there is a limit to what we can achieve in terms of resolution. We pay a price because as you try to increase your resolution, your signal to noise starts to drop and your images become noisier and noisier. So that's where a higher field strength comes into play. The higher the field strength, you can get better and better as well. I mean, the potential jump from 3 Tesla to 7 Tesla is 4-fold improvement in signal to noise. Of course, at this point, we are only able to exploit about 2 to 3 times improvement, but with improving understanding of how to exploit this gap, we'll be doing better and better. So when you can get 4 times the signal to noise compared to 3 Tesla, we can get potentially 4 times higher resolution, meaning thereby, for example, like 3 Tesla, a reasonable resolution for an MRA, which is MR angiography, especially of the brain, we can get to about 0.6 millimeter isotropic resolution. We can drop it enough further, but the image quality will start to suffer and will take longer and longer to acquire the data. With 7 Tesla MRI, we have been able to go to 0.2 millimeter, meaning thereby that we have this 4-fold improvement in image resolution. Actually 8-fold, because you are actually more than 8-fold when you talk about the volume. So that's where the role of higher magnetic field strength comes in. means that we are able to resolve better and better structures. But that's just the resolution part. There are also important differences, as we will talk about as we keep going, that there are important differences in image contrast. So there are certain kind of image contrasts that do phenomenally better at 7 Tesla. For example, susceptibility weighted imaging can really take a major jump from 3 Tesla to 7 Tesla. So today we're going to talk about some of the emerging applications. In last 3 years, since we sort of installed our 7 Tesla magnet, we only have one magnet. We have about 16 other magnets, and there is one 7 Tesla magnet. So it is very useful for specific kind of applications. Not everything is a solution to everything. We have to sort of choose our technology and apply it in the right places. So that's the experience I'm going to share with you shortly. So we're going to talk about some of the challenges, and I'm not going to go too much into the technical detail. And my idea is to show you broadly by images as to what we have been able to accomplish, where we can get as we compare it to 3 Tesla, what have been able to do, mostly anatomically. The functional applications are still more challenging, and I think there's a lot more work to do when it comes to functional imaging with 7 Tesla. Okay, so one of the challenges of 7 Tesla is here. So if you can see that the B0 field, which is the principal magnetic field, which should be ideally homogeneously across the magnet, should be 7 Tesla. There's a lot of variation, and this variation not only comes from intrinsic variation, but when you place a patient in the magnetic field, it actually does a lot of sort of dirty things. It means that there are some parts of the body which are magnetically susceptible, some have diamagnetic properties, means that the field drops in certain areas and goes higher in certain areas. So you can see that there is a lot of variation. So this is actually an intensity variation which is related to the B0, the intrinsic field of the magnet. So you can see there are a lot of challenges for images to be obtained before we can get some semblance of homogeneity, right? So you can see that there is a lot of signal dropout close to the skull base, and there is a lot of inhomogeneity. But with some tweaking of techniques, we've been able to overcome this difficulty to a significant extent. We're not perfectly there. We're getting better slowly. All right. And then there's another field called the B1 field. The B1 field is a so-called radio frequency field. So as you excite the body parts, in order to retrieve some signal from the brain, you need to excite it first and then sort of wait for your T1 and T2 times and get the signal and all that. So this is the variation of the B1 field. So B1 field is pretty strong in the center and it drops out on the periphery. And that poses another challenge for 7 Tesla imaging. So these problems are actually far fewer and far easier to deal with at 3 Tesla. There is no such problem at 1.5. Practically, you can just not worry about B0 and B1 fields at 1.5 Tesla. But at 7 Tesla, there is a considerable worry, and that comes from the wavelength. So basically, the wavelength at 1.5 Tesla, the RF radio, at that radio frequency excitation, the wavelength is about 52 centimeters, meaning thereby that your signal across the width of the body or the body part is almost negligible. But when it comes to 7 Tesla, you're talking about a wavelength of 11 centimeters. You can see there is a significant variation in signal. So that's a challenge that has to be mitigated before we can get anything meaningful at 7 Tesla. But fortunately, with advancing technology, coil technology, and parallel excitation techniques, we have been able to a reasonably good extent overcome this limitation and get reasonably good clinical sort of homogeneity of the RF field. Right. So what we have been able to achieve is, if you talk about the in-plane resolution, basically you can get, so when we talk about MR resolution, we're talking about either a voxel-wise resolution or a pixel-wise resolution. So you can either get a volumetric imaging, which could be an isotropic, or you can have a certain slice thickness. For example, if you're talking about a 2 millimeter slice thickness, you can drop the image resolution to about 0.2 mm with the help of 7 Tesla. So you can see that if you look on the left image, we are able to actually see very good detail of gray and white matter. We can see these small blood vessels that actually go through the cortex, go through the thin stripe of cortex. So this was not able to be resolved with 3 Tesla magnet. So with 7 Tesla, we can see close to the ultrastructure, meaning that we go to about 0.2 mm. Okay. So one of the major applications of 7 Tesla has been epilepsy. And why epilepsy? Epilepsy is one disease process among other processes like stroke, where imaging has made a critical difference between having epilepsy and not epilepsy. So we'll talk about, as you talk about epilepsy, as you probably know, who do imaging of epilepsy, that epilepsy comes in several forms. And one is called the focal epilepsy, where there is a focal irritative zone in the brain from which the epilepsy originates. And there is almost always, whether it is detectable or not is another matter, but there is almost always a subtle structural abnormality which leads to epileptogenesis. And those abnormalities can be entirely microscopic. So they can range from gross microscopic abnormalities to extremely microscopic abnormalities. And the task of an imager is to get closer and closer to the microscopic resolution in order to detect more and more of them. And detection is the first sort of starting point from which we can think about surgery. So either you ablate them by some sort of a laser or sort of radiofrequency ablation or some sort of a surgery. But unless we can detect it, we can't really know where to start. So 3 Tesla and then 7 Tesla on top of it has a major dent in detection of very tiny epileptogenic lesions, as we will see. So basically, once we can detect the lesion, your success rate goes about twofold. So anyways, I'm going to skip this in the interest of time, but these are some of the key sequences that we use in MRI of epilepsy. And each of these sequences critically benefits from higher resolution and greater contrast. Okay. So what do you guys know about hippocampus? How many of you have heard of hippocampus and do imaging of hippocampus? Okay, all right. So anyway, hippocampus is a structure that lives in the medial part of the brain. It's called the temporal lobe. And I'm going to not go into the details of this, but just to give you a little overview, it's about a centimeter and a half wide and about 3 centimeters or 4 centimeters long, sits around the brainstem. And it is critically involved in genesis of epilepsy. A lot of epilepsy that we see arises in the hippocampus, and it has a very fine detailed structure. And the abnormalities can be sub-millimeter in size. So obviously there is a role for going to higher resolution. And that's where 7 Tesla comes in very, very handy. I'm just going to skip this, but I'll show you that there is certain parts of hippocampus. So a part of hippocampus is called the cornu eminence, which is highlighted by this sort of ochre yellow color here. And you can see that on a higher resolution image, you are able to actually replicate this quasi-histological anatomy of hippocampus. And the other part of the hippocampus, which lives in the middle, which is called the hilum or the infolium, is also able to be seen at a high resolution MRI as a central structure. And with little experience, we can really understand sort of subtle variations of hippocampal anatomy and subtle changes that occur in disease states. And again, I'm not going to go into the detail. And then we can even subdivide the hippocampal hilum into a more central region, which is highlighted by the red, and there is a more peripheral envelope also the dentator. So all these structures can be begin to resolve them at 3 Tesla, but then we can resolve them reasonably well at 7 Tesla. All right, let's keep moving. And so what are the differences in resolution between 7 Tesla and 3 Tesla? So hippocampus slice thickness can be dropped from about a 2 millimeter slice thickness, which is typically contained in a coronal plane. And we can drop the slice thickness to about 1.2 millimeter. And if we push the sequence a little bit further, but we'll have to scan for a little bit longer, we can drop it down to about 1 millimeter. But that would increase the scan time to about 10 minutes, which is a little bit impractical. So in order to keep the scan time under 6 minutes, we stick to 1.52 mm slice thickness. But what we have been able to do is that we are able to drop the resolution to about the half of the original, while the SNR is about twice. So even by dropping the resolution to about sort of half of the original, we still have an SNR or a signal to noise ratio, which is twice of the 3 Tesla. So you'll see that with that, we have a 6-fold increase in voxel resolution at 7 Tesla as compared to 3 Tesla with a comparable SNR. So what I'm showing you on the left is actually a cadaveric MRI, and that required 12 hours of scanning. So this is the 9 Tesla magnet, on which a cadaveric brain has been imaged for about 9 hours overnight. And this is about, we are able to do about in 6 minutes at a clinical 7 Tesla. I don't want to look, it looks as pretty, but we are getting close. So we are able to resolve the basic structure reasonably well. Okay. The reason why the slice thickness is critical in imaging of hippocampus is because hippocampus folds. It has a very undulating folded structure. So meaning thereby that if you increase the slice thickness, you will deal with a lot of averaging in that slice. And then you will start to blur the architecture. The more averaging, the more blurring you're going to encounter. So if you drop the slice thickness to 1.2 millimeter, then you're going to reduce your blurring and your averaging significantly. So here is an example of a direct head-to-head comparison in the same patient, a normal individual, a healthy volunteer between 3 Tesla and 7 Tesla. So you can see that even though this change to a naked eye looks, is it really a critical change? But it is a critical change because you are really resolving the structure that much better, especially when it comes to subtle pathology. So you can see that what blurring does. So this is the same position, same slice. One is a 2 millimeter slice, one is 1.2 millimeter, and the image resolution is twice as bad. It means that it is about a 0.3 by 0.3 by 1.2 instead of 0.6 by 0.6 by 2 millimeters. So you can see our ability to resolve the hippocampal architecture or the detail is a lot better. Okay. So you'll see that, of course, you can say that the top image is not a very, very good looking image, but at 3 Tesla, there was a clear question whether the left hippocampus, which is to the right, is normal or not. And those questions keep coming. Another example, whether this is a normal hippocampus or that's a subtle sort of thinning of that part of the hippocampus. Is it artifactual? Is it due to averaging? Or is it real? Very hard to tell. And here's another example of a patient who had kind of considerable blurring of the architecture. This is the best we can do at 3 Tesla in about 5 minutes. And at 7 Tesla, even though the image is a little more grainy, you're able to see the structures a lot. You can see those sort of gray and black stripes much better. So this little stripe is actually a very important critical structure to sort of separate the hippocampal hilum from the cornu ammonis, which is almost impossible to appreciate on the top image. All right. So this is what we are able to see. So one of the important pathology that we talk about, which is a very significant leading cause of focal epilepsy, particularly temporal lobe epilepsy, is hippocampal sclerosis. So hippocampal sclerosis can come from very glaring, very abnormal, clearly abnormal hippocampus that you can perhaps see at maybe 1 Tesla MR or certainly at 1.5 Tesla. Two very, very subtle forms, as I will show you, that you can't even see at 3 Tesla. So this is, obviously a more sort of easy to identify. You can see that there is a considerable atrophy of this hippocampus. All this nice, fat, juicy hippocampus has shrunken considerably, as you will see here. This is a normal looking hippocampus. This hippocampus has shrunk. So this is good. But the anatomic detail is quite staggering. However, this is an example of a very subtle form of hippocampal sclerosis, which is a very focal sclerosis of a part of cornu ammonis, which is called the CM, which is the early part or the most basal part of the cornu ammonis. And this is a patient where the hippocampus was removed. So I actually have a histological correlation. So in this part of CA1, there is loss of neurons here. And almost invariably at 3 Tesla, it would have gone as a normal hippocampus. And this is a 7 Tesla image. And why this is abnormal, because we know, if I go back, the CA1 region should normally taper. It should be fat here and then slowly taper up there. And this, if you compare it to the hippocampal hilum, it's already atrophic. It's small. But these details are hard to obtain at 3 Tesla. Okay, so you basically, just for a comparison, this is what a normal hippocampus should look like. So the visual ratio of the hippocampal hilum, which sits in the center, to this part, which is very frequently abnormal in hippocampal sclerosis, and sometimes can escape detection, excuse me, is actually it relative to the hippocampal hilum. This is atrophic, and that was much easier to detect at 7 Tesla. And again, this is a 3 Tesla MR, and you can see that sometimes it is possible to detect isolated sclerosis or lesion of the CA1 region. Like here also, you can kind of say that this is probably a more global hippocampal sclerosis, but more involved. But again, the image resolution suffers because you don't have enough signal to noise. And you can see at 7 Tesla, you have really no doubt that when you compare to the other hippocampus, this hippocampus is clearly abnormal. You can see there's a considerable shrinking of the volume of this part of hippocampus. But you can clearly see that our ability to resolve hippocampal structure is about 2 to 3 times better at 7 Tesla. And that can make a critical difference in the life of a patient. And there's another form of hippocampal sclerosis, which is isolated to the hippocampal hilum, which is also very difficult to detect at 3 Tesla. Not impossible, but hard to detect. Okay. So that's hippocampus. And I think we are far more confident about calling something hippocampal sclerosis or isolated sclerosis of the subfields or components of hippocampus when it comes to imaging of the hippocampus. I think a greater impact would be felt in detection of subtle cortical abnormalities, as I will show you now. So an important entity when it comes to epileptogenesis, particularly in children and young adults, so up to about maybe 15 years of age, but particularly in young children, is focal cortical dysplasia. Now, focal cortical dysplasia is an extremely subtle abnormality where, at least from an imaging standpoint, all you see is a very subtle blurring of the gray-white matter interface. So usually the gray-white matter interface on a nice T1 or even a T2 images is reasonably sharp. This is a 3 Tesla. So this is as far as it goes in 3 Tesla. And you can see that here you don't really know where the white matter ends and where the gray matter begins. So this is what is called the blurring of the gray-white matter interface. And this is a very, very high quality 3 Tesla. We can show you these regions where there is sort of this loss of definition and there is a little bit of a dirty looking white matter because there is a blend of gray matter and white matter in that region. And you can see that if you do a PET scan, you can sometimes see subtle hypermetabolism, which is important. But these abnormalities can be extremely difficult to detect, even with the best quality 3D. So at 3D MRI, when we were encountered with this problem, we said, how can we do better? So we came up with the new strategy of imaging the gray-white matter junction, which is called the edge MRI. And it is a very simple idea of sort of using an ATI where the gray and white matter signal, actually the T1 recovery is on either side of the baseline. So anything that has an admixture of gray and white matter would be nulled out because the two magnetization would be opposed to each other. So any voxel in which there is partial mixing of the gray and white matter, the signal will cancel out. So what happens? So this is the 3 Tesla image. So you can see what we get in a normal brain is a sharp line that demarcates the gray matter from the white, meaning thereby the cortex is at an intermediate signal and so is the white matter. But any voxel where there is partial averaging of gray and white matter, there will be dropout of signal because the T1 recovery has gone beyond the baseline for the gray matter and the gray matter for the white matter. And the gray matter recovers more slowly, so they will cancel each one out. So now, with this idea, we wanted to take it to 7 Tesla because we knew that our SNR would be excellent. One of the problems of 3D edge imaging is that it is very signal poor. So any sequence that is signal poor will significantly benefit from addition of signal or increment of signal. So, as you will see, we are able to improve our voxel resolution to actually about 2-fold. And we have 2 to 3-fold improvement in SNR. So this is what a 7 Tesla gray white matter junction imaging looks like. So that's about conventional T1 contrast. But again, our ability to sort of see the gray white matter junction has considerably improved. This image looks not only more pleasing to the eye, but have about a 0.4 by 0.4 by 0.4 image resolution. These are 0.4 isotropic images, meaning thereby that we are improving our resolution in terms of a voxel almost 8-fold. So I'm going to show you an example of a frontal lobe epilepsy patient who came to us from Mexico. And there was a question on the PET scan whether there is a little area of hypermetabolism, which was kind of concordant because the patient's symptoms looked like frontal lobe epilepsy, and the EEG findings were also kind of similar. But we don't know exactly where the lesion is. And that's the imaging that the patient came from. And then really hard to tell if there is anything abnormal there. So once you use the edge technique, what you're able to see that there is a little thickening of that edge that we are able to see at the gray white matter junction, but also there is a little dirty looking white matter right underneath, because even in this white matter, there are some ectopic neurons. And since the T1 recovery is different, they somewhat cancel the signal, and you're able to see that subtle abnormality. And you can see that there is a little thickening, focal thickening of the gray white matter junction. You have to see it in various slices, because you don't want to sort of make sure that it is not a slice, sort of a slicing, oblique slicing artifact. But once you have looked at it in 3 or 4 different planes and convince yourself this is true thickening, then you are reasonably confident there is a true focal cortical dysplasia. And at a flare image at 7 Tesla, also we are able to see, and you can also see that at SWI or susceptibility weighted imaging, there is a little broadening of the gray white matter junction. I'll show you more interesting examples than this. So here is a patient who has a focal cortical dysplasia. This is a 3 Tesla MR. Now, one might argue that there may be a little bit of a broadening of the gray matter here. There may be subtle blurring. But when it comes to a 7 Tesla edge sequence, there is very little doubt that there is a considerable broadening of that stripe, meaning thereby that the gray white matter junction is blurred, meaning thereby that the organization of the cortex is not normal. And this was a very confident diagnosis of focal cortical dysplasia, which, when the patient underwent a laser ablation, give the patient complete seizure freedom. As to see how a 3T versus, of course, these are not the same techniques, but this is what we are able to do at 7 Tesla. And again, in the same patient, when you look at the susceptibility imaging, which is another way of looking at the brain, which is another level of contrast, you can see that the white matter underneath this lesion is not the same as the rest of the white matter. So we also find this to be useful surrogate whenever there is a question whether or not there is a focal cortical dysplasia lurking in that region of the brain. This is an additional confirmation that is very, very useful at 7 Tesla. So another example of a focal cortical dysplasia, you can see this is a nice sharp stripe at the gray white matter junction, but you can see there is broadening, and there is sort of this dirty looking brush-like signal that is occurring at the gray white matter junction, which you can also see at a standard T1 contrast. Another example where you can see this broadening of the band was the only means of detecting this focal cortical dysplasia, because the FDG PET was normal. Okay, we'll keep moving, and we can see that these subtle changes in the same patient on other forms of contrast. This is susceptibility weighted contrast. You can see that there is this dark stripe sitting right under the cortex, and the cortex doesn't quite look normal as the rest of the cortex. Now, this would be impossible to see at 3 Tesla. Okay. This is imaging of the gray white matter junction, and of course, another entity that we encounter in epilepsy, heterotopias. Heterotopias are not an uncommon cause of epilepsy. This patient has lots of heterotopias, and of course, I'm not trying to tell you that this wouldn't be undetectable at 3 Tesla. This is probably detectable at 1.5 Tesla. So that's not where we are going. But once in a while, we encounter a patient where if we find an abnormality, and we can easily classify it. So here's an example of a patient who has a history of optic neuritis, and I'm not making it up. This patient has a history of optic neuritis, and she also has poorly controlled epilepsy, came to our clinic, and this lesion was seen. Now, we don't know whether this is a lesion of multiple sclerosis because the patient had optic neuritis, or what is this? Or what is the relevance of this lesion to to epilepsy. So if I'm allowed to go back to this slide, now you can see what happens in heterotopias. So since the heterotopias are lumps of gray matter, they displace the deep medullary veins. So these veins get sort of displaced, and they don't run through these areas of cortical dysplasia. And it's very, very hard to see these veins at 3 Tesla because they are of the order of about 0.2 to 0.3 millimeters. So you don't get enough image resolution at 3 Tesla to be able to see them. But once you see them, you can see clearly that these lumps push these small veins outside on their periphery. So you can take advantage of this phenomenon when it comes to further classifying this into whether this is an acquired abnormality of like a demyelinating plaque or something else, or whether this is truly a cortical dysplasia. At 3 Tesla, there is really not enough resolution, not enough signal to really tell, and you can see that there is a little hazy signal in that location. However, at 7 Tesla, what you can see that this area is behaving like gray matter as the rest of the gray matter, and also the blood vessels are pushed out. It means that no deep medullary vein is running through it, meaning that it is not a demyelinated lesion, and I'll show you demyelinated lesions later. So we have added confidence that this is not a plaque, and it seems to fit the criteria for a isolated solitary gray matter heterotopia sitting right by the ventricle. Okay. So where does the 7-Desi MRI in this current understanding fit in? So any patient who has a negative 3T MRI and semiologically, meaning by the clinical presentation and electrographic recording such as EEG, even detailed EEG, suggests a focal epilepsy. If the epilepsy is generalized and onset, there's clearly no real for imaging. But if you have focal epilepsy and if your 3T MRI is negative, then clearly there's a role for 7 Tesla imaging. If there's a questionable abnormality at 3T which you want to resolve further, get a little more clarification, that's clearly a role for 7 Tesla. In our center, we have started to use 7 Tesla as the first line imaging for focal epilepsy. There is clearly a learning curve, but I think within a year of experience, you can get very good at it. Unfortunately, it is not currently FDA approved for anybody under less than 30 kilos. So it is appropriate for anybody under, I would say, over age of 8 or 9 years, but unfortunately, we can't use it for anybody who is less than 30 kilos. And I think that will get better as our understanding of 7 Tesla and the sequences become less intensive for what is called SAR or specific absorption ratio, and that's a concern for children. But I think it is going to get better as we get to sequences which are less intensive for SAR. Okay. So now let's start talking about other applications of 7 Tesla imaging. So next important application of 7 Tesla imaging is 7 Tesla MRI. So one thing that is very interesting about 7 Tesla, as you perhaps have read about at field. So as the field gets stronger and stronger, the T1 recovery becomes slower and slower, meaning that it prolongs the T1 recovery. And a major advantage of that is that if for time of flight imaging, if you were to suppress the background would remain suppressed for longer. It means that you don't have to keep exciting it, because if you keep exciting the tissue to keep it suppressed, you're also killing the signal that is coming from the artery. So basically, if you once suppress it, it will remain suppressed for long. So that clearly enhances the time of flight signal. And the other interesting fact about time of flight signal is the higher the resolution, the better is time of flight signal. Meaning that the intrinsic time of flight signal goes almost linearly up with the voxel, inversely with the voxel size. Meaning by half the voxel size, about twice as much SNR you're going to get from a time of flight signal. So this is a tailor-made situation for 7 Tesla. So now you can get 0.2 to 0.3 millimeter isotropic resolution. So you can start to see microscopic arteries, and I'll show you. So here's an example that we had in our clinic. It is an aneurysm. It's an ophthalmic aneurysm, and you can see that at 3 Tesla, you can kind of see the aneurysm. You can see the ophthalmic artery, but your detail of this convoluted, very sort of ugly-looking ophthalmic aneurysm, which has a lot of lobulations, is so much better. And if you look at it, if you look at your arteries here, you can clearly see that you can see the perforators in great detail. smaller branches, so detail is a lot better because our resolution in signal is sort of resolution is about threefold better. The typical resolution for MRI that you can achieve at 3 Tesla is about 0.6. You can go to 0.5 at most, and you can go to 0.2. So meaning whether you're resolving smaller arteries, and on top of it, your signal to noise is about 3 times better. So this is a perfect, it's a perfect storm that brings excellent images at time of flight imaging at 7 Tesla. So here's a comparison of a collapsed image of a 3 Tesla MR and a 7 Tesla. You can see far more peripheral arteries. The definition of the contours is a lot better. So there's a question of vasculitis. You are far more confident, and you're able to see the blood vessels much further out. So here's an example that I picked from literature. It's not my own case, but it was a kind of a nice. You have a little bump in the contour of an artery, and then you don't know whether this is an infundibulum. Infundibulum is basically a little dilatation at the origin of a branch artery, which is a harmless, benign entity by and large. And if you don't identify a blood vessels, then you have to worry that this is an aneurysm, and that perhaps will require a more definitive test like a DSA to make sure that it is not an aneurysm. So we are already beginning to see the promise of 7 Tesla imaging in distinguishing aneurysms from infundibulums. And this is a case in point where there is a little bump here, and we're not sure whether this is truly an aneurysm infundibulum, but you can see the artery arising from the bulge, and you can be pretty sure that this is not an aneurysm. And so you can see the quality of imaging. You can see smaller arteries. You can actually see. So you were reading about these thalamo-geniculate arteries, and you learn of these choroidal arteries. You talk about anterior choroidal, lateral posterior choroidal, medial posterior, all these arteries that we see enlarged when there's an AVM or whatever, but we are hardly able to ever see these arteries on standard imaging. But now you can see all of these arteries as standard 7 Tesla imaging. You can see anterior choroidal, sometimes anterior choroidal is duplicated, the early branching of anterior choroidal, a second and third order branching of anterior choroidal artery can be seen at 7 Tesla. So isn't that great? I think it's great. Okay. So, and again, I'm showing you the detail that you're able to get 3T versus 7 Tesla. But where does that detail come handy? Another case in point. So this is a patient where we were worrying whether this is truly a aneurysm close to the basilar summit or this is an infundibulum. And so the next test would have probably been a DSA. But then 7 Tesla again tells you that there's a perforator artery, a thalamoperforator is arising at the top. So again, you are very confident this is not an aneurysm, nothing needs to be done. Okay, this is sort of an overall glimpse of 7 Tesla MR. There's a lot of detail to it, but I just skipped the details just to show you what we can do, where we can get. Now let's talk about multiple sclerosis. We all know that it is a demyelinating disease, and we know histologically that multiple sclerosis happens around small veins in the brain. At least in the white matter, we have known for a long time that it is centered on a vein that is traversing the. How can we exploit it? Okay. So these medullary veins are of the order of about 0.2 to 0.3 mm. So they are beyond the resolution of a 3 Tesla MRI. At times when there is a central plaque of multiple sclerosis sitting right by the ventricle, you are able to see the central. But it is a rare. If you have about 20 plaques, perhaps in 1 or 2 plaques, you want to see a central vein, and if you're lucky. But at 3 Tesla, we are able to very consistently see it about 80 to 90% of the times. If you're not dealing with averaging or slice thickness, we are able to see the central vein. So what is the value of that, as we will see? So a question comes very often once you start practicing multiple sclerosis. A lot of times, a young patient will come with lots of white matter lesions, and they will have lots of non-specific symptoms. They will have some numbness, paresthesia, questionable weakness. And the question is whether this is multiple sclerosis or this is some unusual hereditary or some other poorly understood small vessel ischemic disease. It's a question that comes quite often. And then we got a lot of referral at the clinic with patients who have been misdiagnosed as multiple sclerosis because they started to have white matter disease at a relatively early age, or or they didn't have this risk factors for stroke or small vessel disease. They didn't have diabetes, they didn't have hypertension, but nonetheless, they have these white matter abnormalities. A lot of these migraine patients sometimes who have this sort of subtle, small, sort of bifrontal predominantly abnormalities, they're sent to us with the diagnosis of multiple sclerosis. And then we don't know. I mean, we believe it is probably not multiple sclerosis, but then you can rule it out. In the acute phase, you're diagnosing multiple sclerosis by CSF tests is about 60-70% by detecting oligoclonal bands. But when the disease is not in the active phase, you really have no way of knowing whether this is truly multiple sclerosis. So 7-Tesla MR actually does very well. So here you see there's an example of a small vessel ischemic disease case where you can see none of these lesions are really centered on a medullary vein. And then we use what is called a gradient echo, T2 star. You can use susceptibility weighted imaging as long as it has enough signal to noise. And then here is a classic multiple sclerosis plaque, but you can see the lesion is centered on a vein. And we must remember these veins get smaller and smaller as we go towards the cortex. So these are veins that are draining from right under the gray matter into the central venous system. So as you get more and more peripheral, your ability to differentiate these subcortical white matter hyperintensities from multiple sclerosis to another type of disease gets better and better. So here is a head-to-head comparison of a small vessel ischemic disease patient. This is the same sequence, which is a T2 star weighted sequence. You can see in none of these you see any central vein. The distribution is quite similar, and I think we will have a very hard time if we didn't have this central vein sign available to us. We would have a very hard time telling what's going on. Another example, this is a 45-year-old, and you can see that there is no central vein here. And another lesion here, no central vein. We know that this is not MS. Okay. Here's another patient who's got a lesion in the corpus callosum. I mean, corpus callosum lesions can happen in small vessel disease, but your antennas are up when you have a lesion in the corpus callosum, and then you wonder what's going on. But again, if you look at these lesions, none of these lesions have this orientation along a deep medullary vein. And this detail is impossible to get with 3-Tesla. All right. So that's about the excuse me, white matter plaques. How about cortical plaques? Have any of you heard of or seen intracortical plaques in MS? Very rare. In fact, we don't even understand what intracortical plaque mean. What does it mean for the disease process? Because most of the intracortical plaques are described in path literature, not in imaging literature. Only in last 5 years or so, we are beginning to understand white matter, of course, gray matter abnormalities in multiple sclerosis. There are 2 or 3 important reasons why we want to know them, why we want to study intracortical lesions. One, intracortical lesions are very specific for multiple sclerosis. In differentiating multiple sclerosis, not only from other diseases like stroke or whatever, but also from other demyelinating diseases. It is a very, very specific feature that happens only in multiple sclerosis. So if you have the ability to detect intracortical plaques, you want to be able to assess the cortex. You'll be able to get more detailed structure of the cortex, and that's again where 7-Tesla comes in. So again, I'll show you how we detect intracortical plaques. So here is that same T2 star gradient echo image. And you can see that there's a nice intracortical lesion here. And we now classify the intracortical lesion in 3 types. If you allow me to go back to the previous slide here. So these are classified as sort of type 1, 2, and 3 type of sort of intracortical lesions. So one that starts right at the PL surface, does not go all the way into the white matter, ones that is completely intracortical, and the other that involves the gray matter and the underlying white matter. We don't know what they mean. This is just an anatomical classification, but unless we are able to detect them, we don't know really what intracortical demyelination means for a patient, what it means for the treatment, what it means for prognosis. We have no understanding of this. So only data comes from post-mortem studies. So if you want to go forward, do a drug trial. I mean, we know that the drugs, when we are assessing drugs for multiple sclerosis, all we are looking at how the white matters are evolving after treatment. But we're not looking at the intracortical lesions. Not all drugs might work for intracortical lesions. We don't know. So this gives an additional tool to study multiple sclerosis in evolution. All right. So you can see that we have various ways of identifying intracortical plaques. This is that edge sequence, which shows you with good eloquent detail where the lesion is. This is a standard T1 contrast, and that's a standard T2 star rating. One of the things that we detected, we identified intracortical plaques, which is not even described in path literature. None of the path literature talks about this feature of intracortical plaques, that intracortical plaques happen to be centered around a large cortical vein, a vein sitting right at the surface of the cortex. And this is a feature that we have found invariably in intracortical plaques. And this gives us a strategy where to look. And I think this probably has an important implication for understanding of the pathophysiology of MS, as we will learn later. But none of the path literature has talked about this. And we've seen this almost invariably at this higher resolution. Again, just to sort of highlight that. So here is a deep penetrating cortical vein, and there is a large cortical vein sitting right at the surface, and the plaque is almost invariably centered. I'll show you another plaque. You can see almost invariably centered around so this is a type 3 plaque, which involves a little bit of gray matter and a little bit of white matter. And again, this is another plaque. You can see another cortical vein sitting right on top. This is actually a plaque that was thought to be just a pure white matter plaque on the flare sequence, but on higher resolution, you can see that the plaque extends into the cortex. You can see that the plaque extending. Again, there is a relatively larger size cortical vein sitting right at the edge of this plaque on the PL surface. This is perhaps a classic type 2 plaque, which is intracortical. You can see it's again centered on a cortical vein. So this is our understanding of multiple sclerosis, meaning thereby what have we been able to achieve going to a higher magnetic field? One, that we are able to classify the diseases better. We have greater degree of confidence in calling something multiple sclerosis. We are able to see intracortical demyelination, which was very difficult with 3 Tesla. I mean, we had some success, but then we didn't understand the microanatomy as well as we do now for 7 Tesla. And we perhaps will shed more light about the features or some of the histological features which have not even been described, and we perhaps be focusing more even on histologic studies now that we know that this is how it happens in vivo. So ex vivo is helpful, but if you can detect this in vivo, that is even better. Another disease that you perhaps have heard of, or even though people who do neuroimaging routinely, is motor neuron disease. So diagnosis of motor neuron disease is largely clinical, but there is a lot of overlap with other disease processes, and sometimes we don't know what's going on, whether it's truly early motor neuron disease, whether this is normal, whether this is something else, because they can have upper motor neuron features, they can have lower motor neuron features, hard to classify. So this is it's a prototypical disease where diagnosis in the early stages can be quite challenging. Here the MR is very useful, and we know that even at 1.5 Tesla MR, sometimes we can see this abnormality. So what happens in motor neuron disease? That there is increased deposition of iron in the primary motor cortex. There is normally increased iron deposition, which continues to increase with age in normal individuals, and hence it can be challenging to differentiate what is normal, which is related to aging, versus what is pathological related to the disease. So at 1.5 Tesla and 3 Tesla, we used to make a visual sort of assessment. Hey, this looks more than normal, and this is perhaps abnormal. And in the context of the disease, we believe that this is ALS or motor neuron disease. But our level of confidence wasn't great because we weren't able to resolve these structures better. At 7 Tesla, what we learned, of course, this is preliminary data, we are about to publish it and you perhaps see it. What we found that in normal aging, I'll show you this a little bit more detail. So let's just go to normal aging first. So in normal aging, iron deposition occurs across the width of the cortex, right? The entire cortex will show you will appear darker. So anytime there is deposition of iron, you will have a single dropout and that area will look darker on this kind of an MR sequence, which is called either a T2 star weighted, which is a gradient anchor T2, or some sort of a susceptibility weighted imaging, which is tailored to detect increased iron in the brain. But so we used to make a subjective judgment at 3 Tesla imaging. Is it abnormal, not abnormal? So what I wanted to show you that this is a patient of ALS. This is a normal individual. It's very hard to tell, and they are about the same age, whether this is truly abnormal or not. We don't know. This could be just related to age. This is the same patient. When we go to the previous slide, what's happening here? So this patient has a special kind of motor neuron disease, which is called the pseudobulbar palsy. So in pseudobulbar palsy, you have iron deposition only in the more lateral parts of the cortex, which actually innervate the face and the brain, which are going to space the face and the eyes. So these patients have like what's called a pseudobulbar palsy, whether they have sort of problems with expression, they have swallowing difficulties. And this is a special kind of a clinical presentation of motor neuron disease. But then now we're able to see that in these specific areas of the brain, the deposition of iron is not in the entire thickness of the cortex. It is restricted to the deeper layers of the cortex. So you can see that it is not extending to the peel surface. It is in the inner layers. This was impossible at 7 Tesla. And now we are able to make a more confident diagnosis of ALS, not because there is increased iron deposition, because a more specific pattern of increased iron deposition. So this is what improved resolution can do. And it is not hard to understand that 7 Tesla would do a better job. Not only because this is improved resolution, but also the signal that is associated with signal dropout with iron deposition. So 7 Tesla MR is sort of boosting both properties or both abilities to sort of find these abnormalities. So again, this is the same patient. You can see that the deposition of iron is in the deeper layers. It doesn't extend all the way out. Whereas in normal aging, you can see that this is happening almost across the entire width of the cortex. All right. I mean, I could show you other applications. We'll be starting to use it for cell wall imaging. We are starting to use for dementia, cerebrovascular reserve imaging. But just to keep it short and just to sort of be able to give you a glimpse of what we have been able to do. I hope you enjoyed it. I hope you learned something, and I hope you're excited about 7 Tesla. And I would strongly advocate for acquiring a 7 Tesla at this institute. I have long ties, and I am very close, and I am so joyful to be back here. And if I can help in any way, help support the growth of 7 Tesla here, I'll be truly honored.
Thank you. Very illuminating. We have unraveled several conditions in the brain which we fail to detect on 3 Tesla. And of course, 7 Tesla will definitely have a role, because if you increase the magnet strength from 3 Tesla to 7 Tesla, doubling, not doubling, but more than doubling the magnet strength, and at the same time the signal to micro.
Yeah, absolutely.
And in most complex disorders like refractory epilepsy, where we fail to detect the microscopic abnormality, I think 7 Tesla is going to happen.
Absolutely.
First evaluation, you have highlighted several conditions. So, Bivek, it has been a wonderful journey with you, because you served here as resident in the Department of Radiology. Then you spent some time with us also as a senior resident before he went to US. And he did his residency from Yale University, Connecticut. Then he did his fellowship in Neuro-Radiology before joining the clinic. There he has been just the best educator twice in his career there. So it's a phenomenal, I think, achievement, and AIIMS should feel proud. Student has done such a remarkable work, and I thought since he's coming to India, why not take his advantage? And of course, he has shared his experience, so naturally there's a lot to do in such service. And AIIMS is certainly working. So I can open, if you don't mind, I can open the board and take few questions from the. Yes, sure. Thank you for coming.
Once or twice, and it was quite noisy. So, what's the difference between 3 Tesla and 7 Tesla in regards to the noise and the duration?
Sure. So noise is not any bigger or any more problematic than 3 Tesla. I mean, noise is happening more from switching of the gradient. So the gradient performance is very similar at 3 Tesla and 7 Tesla, maybe a little bit stronger, but it's very comparable. So the noise is not a problem, and it is easy to sort of take control of noise by sort of appropriate shielding. Noise is not a problem. The problem sometimes happens because the gantry is long, it's more tubular and it's a little bit narrow. So there's a little more claustrophobia, but that can also be managed. I think most patients can be sort of primed with time to do this. But at times we have to sort of stop the imaging because of claustrophobia. Claustrophobia is a slightly bigger problem than a 3T, and not of 3Ts are now coming in with a sort of a short bore, open sort of magnets. So I think that's a problem. It's not a huge problem, it's a minor. In terms of time, I would say the imaging times are about twice as long at this time. We are trying to implement strategies to shorten them. One of the important strategies that we see in future is called the sort of deep learning based reconstructions, which are already happening in CD. So basically, it's an undersampling technique where the deep learning algorithm will learn as to what are the most critical pieces of acquisition and where there is a lot of redundancy where you're not generating any signal, but it is just a redundant data that you're acquiring. So a lot of deep learning strategies in next 2 to 3 years will perhaps shorten the time of about 40%. So from about, I think the average sequence is about 6 to 8 minutes as compared to maybe 3 to 5 minutes at 3 Tesla. So that's a little bit of a problem, but most patients are able to do okay. Even our patients who have tremors and dementia, I think we get reasonable imaging. But once we sort of implement these deep learning reconstructions, the imaging time would probably come down by about 3 minutes or so. So it'll be comparable at the upper end of 3 Tesla, maybe 5 minutes, 4 to 5 minutes. So the other problem that happens is as you are entering the magnet, so field actually changes pretty rapidly, and the field is homogeneous only at the very sort of center of the gantry. So as you enter the gantry, there's a very rapid change in the magnetic field. So some people feel dizzy. Even I felt dizzy, but it lasts only about maybe 10 seconds. Other than that, I think the tolerance is excellent. Safety profile is excellent. We haven't had any issues. Noise is not any worse, but not any better.
Thank you.
Sure.
So as of now, we don't have anything which is silent about.
There is nothing like that. Actually, we are working on a technology on the side for noise cancellation. So I'm a part of a venture at Mayo Clinic, and we are sort of preparing a tool which will use active noise cancelling. And about some of this is already available, but we are trying to sort of use an intelligent algorithm that will adapt and will actually cancel the noise by about 80%. But that'll be helpful. But noise, as I said, the noise is not any worse problem than 3 Tesla.
Right now, I think we are looking at only 60 centimeter bore size in terms of Tesla.
Let me show you this. I don't remember offhand, but we can go home. Let me see.
Do you have any other question? Yeah, please.
Okay. So here is it. So you can see the bore side is 60 centimeter, and those are the specifications. So it's a long bore magnet. It's a long bore magnet. It's a very narrow tunnel. You do feel a little claustrophobic.
The weight is too heavy.
It's heavy, so it needs special, and it's expensive too. It's about 4 or 5 times more expensive than a 3 Tesla magnet. But I think it is definitely worth it because it can be a game changer for certain kind of patients. It's not something that you apply for everybody. You have to be selective. You have to be very judicious where you use it. But once you know where to use it, it can be a game changer. It has been a game changer for us in many cases.
Shielding is too elaborate.
It does require a lot of shielding. It does require special preparation, but that all has been worked out. So you need a space for it. You just can't put it in any space. So we have a separate MR facility where we have 2 3 Tesla magnets and 1 7 Tesla magnet. But it is attached to a clinic. It means that once it is shielded, you can have a sort of movement around it. It's not a problem.
Yes, enough.
Thank you, sir, for that
enlightening talk. These are definitely futuristic times for neuroimaging. So my question is regarding the use of rate 7 Tesla imaging in demyelinating diseases. So we talked about the central vein sign. So is every plaque associated with the central vein sign, or you have certain demyelination in which there is the lesion is not passing, the vein is not passing through
Correct.
the
Correct.
plaque.
Correct.
And in a continuation of that, I have another question. Like often we find these non-specific imaging abnormalities when patients get imaged for other indications like headache disorders or epilepsy. So how does 7 Tesla MR help in evaluation of in differentiating this from a demyelinating plaque?
Correct. So I would say that demyelination, occasionally in acute demyelination that is associated with ADM and like conditions, you can have central vein, but there's no specificity. There's no real propensity for other demyelinating diseases to be centered on a vein. So it's a relatively specific sign of multiple sclerosis. So I think it helps us classify the demyelinating disease better. But I think most of the demyelinating disease, differentiating between, for example, a neuromyelitis optica or MOG-related demyelination, which is sort of a surrogate of ADM. We understand that a lot of them have MOG antibody positive. I think it's not that hard based on imaging. I think they have a slightly different imaging pattern. The lesions are larger. They don't have this specific distribution around the ventricle or corpus callosum. I don't think that's the problem. The main problem is the ischemic disease, small vessel ischemic disease, and that can be problematic. And that's where I think, so you can have a small vessel ischemic plaque or small vessel ischemic white matter lesion just accidentally be centered on a vein. But since there is no real propensity, I would say only less than 2%, 3% of these accidentally happen to be centered. Whereas overwhelming majority of multiple sclerosis lesions, I think almost all multiple sclerosis lesions are centered on a vein, whether you can see it or not. And since you can resolve those veins at 7 Tesla, you see, I think you can read our paper, in more than 80%, 90%, you can see a central vein. So that's where we are at this point. And we are also improving our ability to detect intracortical lesions, which are very, very specific for MS. And I think it has a lot of implications for future treatments, because we haven't really factored in intracortical demyelination in treatments or prognosis. Once we have a confident ability to detect them and classify them, I think that will impact the clinical management of multiple sclerosis. So that's the other advantage. But that's where we are at this point. Hopefully, we will learn more.
Yeah, please.
Hello, sir. Thank you for the wonderful talk. Actually, I wanted to know that we say that MR 7 Tesla has increased sensitivity compared to 3 Tesla MR, right? So is the sensitivity increased across all the sequences, or there are particular sequences along which it is increased, or all the sequences like epilepsy or epidural or perfusion? So all the sequences have increased sensitivity.
Sure. So when we talk about sensitivity is kind of not the right word to use. So let's talk about image resolution. So image resolution is going to go up across the board, because with the improved SNR, you are able to drop down your resolution without compromising on your signal to noise. So one of the things about, as you know, in MR, as you try to go to a smaller and smaller resolution, you start to compromise your signal to noise. They are sort of linearly, inversely proportional. So if you have 4-fold signal, or at least clinically achievable 3-fold signal, you can theoretically drop your resolution by 3-fold. So that is going to happen across the board. And that up to you how you want to use it, whether you want to increase your signal or you want to increase your resolution, or a compromise of both, or some sort of a combination, however you want to use it. So that is across the board. However, 7 Tesla does open new opportunities for contrast. For example, the susceptibility weighted signal is much higher because there is shortening of T2 star. So T2 star shortening is considerable. So what happens is that you are able to get much higher contrast with those kind of sequences. For example, I showed an example of what is called an edge sequence. So edge sequence is intrinsically sort of signal to noise ratio poor, in the sense that the signal, it's a very sort of grainy image at 3 Tesla. And that's because we are canceling a lot of signal. The contrast is generated by canceling the signal within the voxel. So for that kind of an application, if you can intrinsically increase your signal threefold, actually I should show you that sequence. I think it'll make intuitive sense. Just give me a second. Let me get there. I think since you asked that question, I think I should take this opportunity to illuminate that. Okay, so here is a sequence which is called an edge sequence here. So this is that 3 Tesla. It is a sequence that creates a thin stripe at the gray-white matter junction. And that's because of the cancellation of the T1 at a particular inversion time. But anyway, that's not the point. So this signal, you can see that how grainy and sort of noisy this image is. Even that stripe is kind of interrupted, looks interrupted, and sort of looks a little voxely because of the problem with the SNR. When we go to 7 Tesla, this is what you're able to get. A very nice, smooth stripe that you see at gray-white. This is a key sequence that we use for detection of focal cortical dysplasia. So you can see how this helps us. I'll show you an example here. So this is a patient who has a very subtle focal cortical dysplasia, which was very hard to see at 3 Tesla. And so this kind of a sequence, which is intrinsically poor in signal, will benefit considerably at 7 Tesla. So I said that I don't know what you mean by sensitivity, but improving resolution is across the board, and certain kind of contrast benefit at 7 Tesla because there is sort of lengthening of T1 and shortening of T2, and a considerably greater shortening of T2 star. So things like bold signal, you get excellent bold signal at 7 Tesla. Hope you understand what that is. And also what happens is because of the improved resolution, you are able to get bold signal from microscopic vessels, not just macroscopic vessels. So you're able to actually see intracortical bold activation. So you don't get those blobs of activation that you get in front of them. You can actually see linear activation in the cortex. You can actually see activation within the layers of cortex. So that's the advantage. So, I mean, any signal which is based on some sort of a T2 star weighted properties will be significantly better. It's not something that you can say because sensitivity is a very sort of generic and a little bit non-specific term.
The second question I'm asking on behalf of Dr. Manjari Tripathi. I wanted to know if we have specific studies that are in terms of MRI negative epilepsy, picking up FCDs, specifically type 1 more than what is seen as MRI negative on fetus.
Yeah. So I mean, we have had some success with type 1. No, type 1 FCDs are really very, very difficult. As we know, type 1 FCDs are most difficult FCDs to detect. And we never talked about type 1 FCDs at 3 Tesla. I think all the FCDs of focal cortical dysplasia that we saw at 3 Tesla were perhaps some variation of type 2, because that's a more macroscopic lesion, a little bit of a dirty gray matter, a little dirty underlying white matter, a transmetal sign. But now we are beginning to see, so this kind of FCD, which has no signal in the underlying white matter at all, so no clue where the lesion is. So this is perhaps some variant of type 1, the one that I'm showing you here, and this one is perhaps some variation of type 1. Now, type 1 can be extremely small to a little bit larger. So those type 1 which are called the architectural distortion or architectural dysplasia, I don't think we have any chance of detecting them anywhere in the next 20 years, unless something sort of dramatic happens. But we are able to see slightly larger type 1s, which we really had no confidence in detecting or telling at 3 Tesla. So that's where we are. So yes, we are able to detect type 1, but the type 1 has to be a little larger than the more subtle types of type 1.
Is ability 70 offer more to neurosurgeons, especially neuro-oncology? Like there are so many changes in the classification of humans nowadays. So will 7 Tesla will give a lead over the current 1.5 or 3 Tesla?
So we believe that it will, but I don't think it has been studied at this point. So at least at our institution, we aren't using this a lot for tumor imaging because our surgeons haven't been asking for it. I think one thing that will happen is that, for example, I'll tell you where we will use it in the near future. So there are now techniques of metabolically imaging the brain. which are not the classic, like the MRS or MR spectroscopy based techniques. There are new techniques to sort of assess the chemical composition of brain, and which can significantly benefit at higher field strength. So what will happen is, if you're about to resect a tumor, or for that matter, if you're about to radiate a tumor after resection, you want to know, and you don't want to excessively radiate the normal brain, you want to sort of contour the leftover tumor, the infiltrative part of the tumor, or non-enhancing. Basically, any GBM is way beyond your surgical margin. So if you want to do the chemical imaging and understand how to sort of modulate the radiation dose, or sometimes even guide your resection, if you believe that there is a very metabolically abnormal region of the brain which is resectable, which is not a non-eloquent part, you want to go after it, even though this wouldn't have sort of qualified by the standard criteria, you can go after it. So that's coming. So we will be able to metabolically image those regions and perhaps give you a better idea of what should the extent of resection be. But that's a work in progress. We are beginning to so the problem is these sequences, as I said, some of the earlier principles are very sensitive to RF field. A slight variation are really going to throw everything off, because that chemical composition heavily depends upon uniformity of the RF field. So new advancement that is coming shortly, which is going to be FDA approved, is called the parallel transmission coil. A new parallel transmission coil is coming. After that, I think we are quite hopeful that we will have homogeneously enough field to be able to confidently metabolically image brain. I think that probably will be helpful. Now, in terms of typing of tumors, brain tumors, some people have used some AI-based techniques in saying that this is IDH wild or this has got this mutation. I don't think they work very well. I think that is perhaps a misguided sort of tour. I don't think it's good for a publication, but I don't think it's going to ever come to any kind of a clinical fruition. So I think the typing is best done the way it is done now. You have to take the tumor sample and just type it, because I don't think imaging will ever get there. Even for saying IDH wild versus non-wild, it totally depends upon your sample. You give it a totally different sample, it'll give you totally ridiculous results. So I think that's a misguided sort of use of imaging, and that's what I think. Yes, tremendously. Your cortical mapping is much better, no question about it. So if you are in an eloquent area, or even white matter tracking, so if you want to make sure that you are not close to an important white matter tract, your fiber tracking is about 3 times, 4 times better. You're able to see fibers that make a sharp turn, which you can't see at 3 Tesla. So yes, that will be and that we're already doing. So we are beginning to, some of these patients who are going to surgery, we are able to use 7 Tesla for sort of a DTI type fiber tracking, and that's a clearly an improved version of pre-surgical evaluation. So I think those are the 2 areas where I think is going to make an immediate impact.
The CIS sequence, many times you are not very clear on CIS when you are seeing a transient and
Oh, yes.
Is it better?
I should have brought some images actually. Yes, it is better. There's a little bit of a problem with the skull base. Again, once we get the parallel transmission coil, you saw that if you go back to this, just a minute, I'll just take you there, and you'll see why we have a little bit of a trouble. Come on. Yes. So when you talk about B1 field, you can see what's happening here, and this is the B0, actually more of a B0 problem. So these sequences are very susceptible to variations of B0. So right at the skull base, sometimes you just don't get enough signal. So with parallel transmission, we will have sorted out some of these problems. Not that much, because parallel transmission is going to help more of the B1 field rather than B0. So B0 will remain a problem. And KISS type imaging, we have done some very high resolution imaging. We are able to see the trochlear nerve now. There's an article in one of the journals, and I can send you, where we are able to see consistently the trochlear nerve, which is of the order of like 3.3 millimeters. So with that kind of a sequence, you are able to see the trigeminal vascular impingement much better. So I think it will help. I think we are able to do a reasonably good job of it already at 3 Tesla, but I think we can do a little bit better. we do have to overcome certain challenges. Once we do that, I think perhaps when I come back here 2 years later, I will show you some images.
Excellent talk, Bivek. That's really, it's truly an eye opener for many. As you mentioned, susceptibility base sequences would be better on 7.
Yes.
Would diffusion sequences also be better?
Yes, of course.
And as you mentioned, metabolic imaging, so MRS will definitely give us a lot more. I think sodium.
Yeah. So that.
P31.
So the problem is, yes. So obviously, sodium imaging can significantly benefit any kind of a metabolic phosphorus sodium. Yes, I think there's actually another strategy that we're looking at. I'm just to sort of go on the lighter side of things. We were contemplating injecting heavy hydrogen, heavy water into CSF, because heavy water, the sessional frequency of heavy water is about 1/6 of that of water. So if you have a special coil, which is sensitive to, which is about 43 megahertz, all you see is heavy water. You just don't see anything else. So you can actually trace the metabolic imaging of water, how water, let's say, for example, normal pressure hydrocephalus, we know that the transition of water through the interstitium is abnormal. We don't know how. So we are hoping to, it's a long process. There is a lot of steps to it. But conceptually, you can do something like this at 7 Tesla. Because the difference between the processional frequencies of heavy water and water is so far apart. The signal you're getting all from heavy water, and the signal that you get from heavy water is very, very little. So you need to have intrinsically high SNR to see it. So any metabolic imaging, sodium imaging, phosphorus is clearly going to be better. But again, there are enormous challenges that you have to sort of deal with before you get there. So it's a sort of it's a lovely fruit, but the fruit is pretty high. You know, you have to jump higher to get it. Was that?
Injected.
No, I mean, sodium and phosphorus imaging, you don't have to inject anything, but heavy water, let's say if you do something like that, yes, you will have to inject it somehow.
I think that ophthalmologists are really keen for us to show our intraorbital nerves. We are not able to do anything of that as of now.
That's the same problem again in the orbit.
I don't think Tesla will help us there because fat and bone.
The same problem again. You have a high resolution, but again, that's a very difficult area to image with 7 Tesla because of all these challenges. Exactly. You have B1 tremendous B0 problem and B1 problem because the closer you get to the coil, then again the same problem. And the coil doesn't do well in the orbit, and slightest movement of the eye is going to screw up everything. So it's theoretically possible. I don't think it's going to be achievable in the short term. It's an interesting. We are able to do some orbit imaging. I mean, some intraocular tumors we have been able to image with great detail, but that's the best we can do. Optic nerve imaging is not bad, but again, there's a lot of challenges. It's a hit or miss. If the patient has a favorable anatomy of the skull base, you're okay. If the patient has a lot of air, big sinuses, I mean, it doesn't do well.
Okay, so Vivek, it's time to conclude now.
Since we are talking about since we are talking about the high resolution, things like acquisition and tropic imaging, I just want to know about how the specific absorption rate, the radio frequency deposition, how much early it rises in surgery.
Yeah, so that's clearly a problem, and that's why we have to be very careful. So what we do is, for example, sequences that are very, very heavy on SOR, like FLAIR, for example, fast spin echo T2, depending upon how you design the sequence.
The gradient sequences.
Yes, so the gradient sequence is a less of a problem. Specific absorption rate in gradient sequence is really not of a problem. It is more like when you are using like repeated 180-degree pulses when you're just pumping a lot of RF energy. So you have to really tailor those C sequences appropriately. So you use like not 180-degree pulses, you use partial, because what is very interesting from a physics standpoint, the RF energy between a 120-degree pulse to 180-degree pulse is about threefold energy. So you take advantage of that. So you reduce it to 120-degree pulse. You're still able to get imaging. You have to tweak the sequence a little bit, but the RF deposition is much smaller. So you have to deal with that problem, but it is still a problem. And the other problem is because there is so much variation in the B1 field, you are not able to you're not able to accurately calculate how much RF is going certain part of the brain. So we have to use the most conservative strategy where the worst possible case scenario is going to be at least would leave a big safety margin. So that does put some limitations on how aggressive you can be. So I don't know exactly how fast or how slowly it rises, but it is a pretty significant problem. And if you need to know more detail, I can put you in touch with my MR physicist who will tell you exactly what the problem is. I'm not an MR physicist. I know a little bit of MR physics, but I don't think I can answer that question intelligently. But it is a significant problem, and that's why we have a weight limit. I mean, anybody under 30 kilos, we can't image children. Because of that, we don't have good ways of accurate modeling of the sort. But it's getting better. That is also getting better as we understand this a little bit better. And with parallel transmission, at least we won't really get rid of this problem, but we will know exactly how much how much RF energy is being given. We'll be able to more accurately measure it.
So, sir, the limits of the SAR is still the 4 watts per kg for 70 or
it's the same. It's the same. It's the same. Yeah.
It's not
No. That comes from the degree of tissue heating that will happen. So that's the same. The safety standard doesn't change. Yes. I'm sorry? I didn't get the question. Screening. Mm-hmm.
The type of diaper that people forget their friends.
People forget their friends.
Oh, before they forget their friends. Oh, I mean, that's a very embarrassing question to answer. And actually, you know what? My only saving grace is that I was about to call him. It's been such a whirlwind to us, Sandeep. I just landed from one place to another, and my phone was dead. And then I'm going to get a beating. I know. I'm going to lose I'm going to lose my hair. I know that. Okay.
So,
All right.
I think we conclude this session. I hope it has been a wonderful session. Interaction. It's my present duty, moment of pride and pleasure, and now you have your question. Those who want to come, please join us. I will. Waiting after.
That is not only from forward.
Just also very proud of you.
Thank you very much. Thank you everybody for joining. It's been such a pleasure for me, an honor for me to be here. I think some great speakers have probably spoken from this podium. Sort of being in their shoes, I don't know how to express it.
We feel proud about it.
Actually, half the people don't know that, you are from here, you did MBBS, and especially the younger generation. I know Vivek since 1985. Sandeep,
You should hang out in the postal. Yeah, right?